We're waiting for Betsy from West Valley Medical Center, and then we should be good to go. Again, just a quick reminder for those who just joined us, if you want to go ahead and mute your microphones and then also turn off your video for now, that will allow the presenters to have the most bandwidth as possible. So if you're not one of the presenters, please mute and turn off your cameras at this time. Thank you. Thank you for joining us for the joint news conference between St. Luke's, St. Alphonsus Health Systems, West Valley Medical Center, Primary Health Medical Group, and Salzer Health. We are going to have a lot of people speaking today, and I'll pull up a slide so you can see the names of the folks here. This is the order in which they'll be speaking. We have Chris Roth, St. Luke's Health System President and CEO, Odette Villano, St. Alphonsus Health System President and CEO, Dr. Stephen Nemerson, St. Alphonsus Chief Clinical Officer, Dr. Jim Souza, St. Luke's Chief Medical Officer, Dr. David Peterman, Primary Health Medical Group CEO, Betsy Hunsicker, West Valley Medical Center CEO, Dr. Don Kaiser, Salzer Health VP Chief Medical Officer, and Dr. Sky Blue with Sawtooth Epidemiology. Now, we want to make sure that you have the opportunity to ask your questions at the end of this news conference. So what we have done is we've created an opportunity at the end for you to ask questions. What you will need to do, though, is keep your microphones muted for the entire process. When we get to the Q&A, we will open it up to that portion. You will see this toolbar here. This right here is a raising of the hand. If you have a question you would like to ask, please press that hand button. We will try to call on you in the order in which we see the hands raised. And at that time, when you hear your name, please unmute yourself by clicking this microphone button, and then provide your name, your news organization, and whom your question is directed to. We want to let you know again, just to go ahead and leave your microphones and your video off through this entire process. And then also, an important note that we want to point out here, just one moment. We are all in separate offices, and we all have our masks with us. The reason that our leaders are not wearing those masks is so they can actually talk with you clearly. But please know that each of them is in an individual office by themselves, and that is the reason that they're not wearing their masks at this time. So let's get started with Chris Roth and Odette Villano.
Well, thanks, Anita, and I'd like to welcome everybody and thank you for taking time to participate in this event. I'd also like to thank all of my provider colleagues from around the Valley for leaning in and helping prepare the shared message. It's been a real privilege to work with all of you over the last few months, and I know we're up for the challenge going forward. Before we dive into this, I do want to offer our sincere condolences to the family and the loved ones of our colleague, Samantha Hickey. Those of you probably heard the news yesterday that we lost a dear colleague in Samantha. She's been a nurse practitioner for 15 years in the Valleys, worked with St. Alphonsus and St. Luke's and the Mercy Medical Center. She's survived by her husband and her 4 children. And it really is a reminder of the gut-wrenching effect of this pandemic, and just tragic. And it's frankly a very stark reminder of why we're here today and what we want to talk about as a collective provider organization. I want to provide a little bit of background to what teed this meeting up, if you will. At the very early stages of this pandemic, Odette Villano and I formed a healthcare collaborative that includes all the providers listed on this call who will participate today, as well as many others. We did so with the intent of sharing information with one another, best practices, sharing data, things like PPE and supplies and what we're seeing in our respective organizations. And one of the messages I want to share with all of you is that the provider community in this region is united. We've been working very closely together. We will continue to do so. And this meeting is really an outcropping of that collective effort. We felt a strong need to share our message and what we're seeing with the community at large, so everybody's more informed and we can talk about what we need to do about it as a collective society. So with that, Odette, I'll turn it to you to see if you have any other perspective to add to that.
Thanks, Chris. And yes, I would like to, first of all, thank you all for joining us. I do want to echo what Chris said. We are a united front. We have been working together as a collective group in respect of what we represent to you as your healthcare providers in the Treasure Valley. We're very committed philosophically and in everything that we do to ensure that the health and well-being of our community is first and foremost. So thanks, Chris. Back to you.
All right, thanks, Odette. I want to start off by talking about what we're seeing relative to trends in Idaho. So I'm going to go through a few data points, and I'll repeat if necessary. First of all, we are seeing an alarming increase in the number of coronavirus cases in Idaho. To put that into perspective, in the first 110 days of Idaho's COVID-19 experience, that's March 13th through June 30th, we had 5,552 confirmed cases. That's 5,552. For the first 13 days in July, we have 5,110. Nearly half of all cases, confirmed coronavirus cases, have occurred in the last 2 weeks in Idaho. Our hospitalizations as a result are increasing rapidly, and we know that there's a 2 to 3 week lag behind following the presentation of symptoms to potential hospitalization for those who need it. Just a data point, and this is St. Luke's data, but it's representative of what other hospitals in Idaho are seeing. On June 26th, we had 20 COVID-19 related admissions. On July 2nd, we had 40. On July 7th, we have 51, and today we have 77. We see no change in this trend, and our projections suggest that COVID-19 related admissions will double every 2 weeks. We're on a course of seeing exponential increases, and until and unless we change our collective behaviors, those will continue. So I want to talk about what this means. The health systems today and our hospitals have the capabilities to care for these individuals. And in addition to caring for those with COVID, we're also continuing to care with all of the members in the community that require clinic visits, hospitalizations, anything they need. But if we do not reverse this trend, we are headed for a crisis. We've seen other examples in New York and Texas and Arizona. We believe we can avoid that situation if we act, and we'll talk about some specific actions that we believe we can take. Before we do that, I'll toss it back to Odette for some further color relative to what we're seeing.
Thanks, Chris. So I want to take us back a little bit through memory lane, full 18 weeks, right, which seems like years for all of us at this point. Since March, we've been on a roller coaster, ups and downs, navigating in this space. And as Chris stated, we know how to deal with emergencies. But sustained emergencies means that we're pulling off all our staff from where they are focused and taking care of the health of our communities to focus on just one problem. In March, we began to stand up our incident command centers, and you can extrapolate from my numbers what that meant to every single one of our health systems. But over 200 people came together, dropped everything that they were working on, and day in and day out were focused on workflows, process, guidelines, shifting, whatever information we were getting based on what we were seeing in Seattle and New York. We were constantly focused on making sure that we had our teams ready to take care of any kind of emerging volume that we would see from COVID patients. Early on, we all, collectively began to talk to each other about taking down our procedures and our surgical volumes in order to make sure that we were ready for this community if the huge surge came. So we immediately shut down, and all we were focused on was COVID readiness. Our infrastructure, not only for our patients, but also for our colleagues, completely changed. And while we were in shelter in place between March and April, not that we're advocating in any shape or form to go back to sheltering in place. But the things that we put in, social distancing, people staying home, people not coming to work if they were sick, hand washing, and early on, a little bit of masking because we were all self-quarantining, for lack of a better word, we saw a significant crushing of that curve. And that led to all of us being able to come back in early May and say, we can start servicing our community as we are to be doing and ramp up. And I would say the ramp up was not like a light switch. It was a way that we began to look at living a duality of COVID readiness and recovery. So we began to rework other workflows in order to ensure that we could first serve our community that had COVID and was being admitted for that, and still bring back all the services that we need to keep our community safe. We are in the midst of now, based on the numbers, we can extrapolate what Chris said. 2 weeks ago we were at 3 patients. Today we're sitting at 41. I mean, just the growth of the number of COVID patients. And we're starting to see younger populations in our hospital that have COVID. But based on what we're seeing, we're all reconsidering in reducing several of our services once again. Now, while we've built a lot of infrastructure and workflows that allow us not to take that cliff dive that we did in mid-March and still continue to service at a much higher level, the impact of using all our resources to refocus once again on COVID is a concern that we have as a community at large. So we hope to be able to provide you a lot of information. I would say over the last several weeks, based on the supply chain getting stronger, we have seen better PPE, better ability to get supplies. However, we are starting to see fractures once again in the supply chain, and I think Dr. Peterman will be talking about testing. But we're starting to hear about the issues with pharmaceuticals again and PPE and potentially a breakdown in the supply chain because of the number of cases that we have across the country. While Idaho is self-contained, we are so dependent on what's happening nationally. And so as a community, I think it's a call to action for us that we will communicate today. And if that's not as compelling, I would urge you to think about anybody that you love or know that works in healthcare. We can have as many beds, as many supplies, but our limited resources of our human capital, which is the most important in this pandemic, are beginning to get sick because of community spread. So we have gone from a month ago having 25 of our colleagues quarantine to today we sit at 123. And we don't have other colleagues to go find to bring in that know our system, that know the workflows that we've put together. So I urge you to really think about not only what we need to do as a community, but to preserve this healthcare system that we have built of great hospitals and health systems in Idaho to preserve the people who are here to take care of our community. So I will give it back to Chris and we'll keep going.
Thanks, Odette. And just a note relative to the health of healthcare workers, St. Luke's and I know other providers are seeing similar numbers of individuals in a proportionate way in terms of their size of their organization. Dr. Souza later will talk about our experience in Blaine County, where we effectively shut down a hospital due to the health or lack of our healthcare workers. So it's a serious concern that we have. We do know how to reverse this trend. We've seen it happen in other countries. We've seen it happen in other cities. We went through a period of time where we effectively shut down the economy and we're at a stay-at-home. And Odette mentioned that crushed the curve. But we need to do things differently and take different actions if we're going to be able to collectively work through this. We can see the schools open and have our economy emerge. It was we certainly saw the devastation of having a stay-at-home order and reducing healthcare services. People put off surgery. They put off the need to receive medical care. And we're seeing those individuals today. And I'll tell you, they're quite a bit more acute in terms of the progression of their disease or condition, and we're seeing that across the nation. We're asking for two things today. First, we're asking for the community to be more vigilant in wearing face coverings, maintaining social distancing, washing hands often, and all of the other behaviors we know works. Do want to recognize that we have cities and local officials who have taken actions and aggressive actions in their counties and cities, and we've got communities that are stepping up and individuals that are stepping up, and we want to thank you for that. This is a team sport, and we're all in it together. Our second ask is that we're calling on all members of the community to contact your local and state officials, boards, commissions, all those who have the ability to make policy. Please contact them and urge them to require the use of face coverings as a community expectation. So those are our two asks. Keep those in mind as we go through the rest of the presentation today and the data. And I'm going to go ahead and turn it over to Dr. Nemerson from St. Alphonsus.
Good morning. It's a privilege to be here today and share some of our data with this group and also some of the science behind the recommendations that we're coming forward with. Today is the day to show you the COVID train has left the station. Idaho is well on its way to becoming another New York, California, Texas, or Arizona, but we have the opportunity to turn that train around with face covering, social distancing, and the self-hygiene that Chris has referenced so eloquently. I want to start with an individual patient story first to capture the picture of what we're encountering here in our hospital, all of our hospitals, and that is the youngest critically ill patient that we have taken care of at St. Alphonsus was 21 years old. And that patient fortunately has done well, but with a fairly arduous course. And the largest growth in COVID positive patients throughout our communities is in the age group of under 30 years old. So we would like to see that change. To set the context for Idaho, I'd like to show you a graphic, the slide number 2, a map of the United States, if I could. There you go. And you see that the nice cream color in large swaths of our country is 100 active cases per 100,000 population. That's considered a moderate incidence of coronavirus. And then if you look to the left and you see that black outline, that is the St. Alphonsus Health Ministry. We serve in Idaho and also Eastern Oregon. And you see nice bright red and burgundy color within that black outline. Those are not colors that we want to have. And the reason we don't want to have that is those are a prevalence of active cases per 100,000 between 300 and 1,000 cases per 100,000, which is considered a very high prevalence of COVID per capita. The other thing to give you as a reference point is when we were engaged in this journey only a couple of months ago, during that first wave of coronavirus that we experienced, we had an active case rate at its lowest not even 2 months ago of 7 per 100,000. So we have in the past 2 to 3 months increased from 7 to several hundred cases per 100,000. With regard to our own experience in St. Alphonsus Health System, we had 2 hospitalized patients in all 4 of our hospitals only 1 month ago. Now we're varying between 40 to 50 cases in all of our hospitals. And we've been compelled, in order to be able to maintain operations and provide those medically necessary procedures to non-COVID patients, to begin to open our hospitals throughout the system to COVID, where we had previously been able to cohort them exclusively at our Boise campus. This graphic here shows you the current increase or growth in cases throughout our Idaho counties, and you see that markedly increased trend duplicate duplicated in our inpatient volume, those patients that require hospitalization. I do want to point out, though, if you look back in early April, you'll see that bump in county level cases with a very small bump in hospitalized cases, which is also concerning to us because it suggests that the acuity or the seriousness and complexity of illness is getting worse. Finally, some other numbers to share with this group. Based on that chart that I showed you in our predictive modeling, we predict that within 1 month's time, we will see a doubling of our total inpatient volume. Within, just let's say by Labor Day, we would expect as much as 50% of our total inpatient volume across all of St. Alphonsus Health System will be consumed by patients that have coronavirus. But we have that opportunity to change that trend. With regard to testing, I know more will be discussed later, but I just want to share some of our numbers. 1 month ago in our mobile testing sites and respiratory clinics, we were testing approximately 20 to 40 patients per day. As of last week, we were testing over 800 patients per day for coronavirus. As a result of that, previously we were able to test patients on demand, which was a tremendous service to the community to allow businesses to be able to function and forward patients or their employees to us for testing to ensure that they maintained a safe environment. Additionally, we were able to help community providers to support patients who might have been exposed to coronavirus and were worried about whether they could transmit that to loved ones, friends, or colleagues. As of that testing burden, we've been forced to now restrict our testing only to symptomatic patients. And the reason being that we need to focus our testing for patients who require confirmation of COVID in order to receive appropriate treatment. And I won't go into detail, but I will mention one important factor, which is those patients who come to us with severe COVID and end up in a critical intensive care unit and require some of the experimental and novel therapies that we are able to provide, those therapies are not without risk. Convalescent plasma, remdesivir, they do have toxicities, and so we need to make sure that we're giving them to patients that we are absolutely certain have coronavirus, not just symptoms. Odette has already referenced the safety of our healthcare workers, the increased exposures that our own colleagues are having in the community, and the difficulty of protecting them outside of our four walls. Inside the four walls, we are able to do extremely well. Outside, however, they are surrounded by people who are not wearing face coverings and practicing hand hygiene and physical distancing. And so, in summary, what I want to say is that the numbers are frightening, the trends are more than concerning, but we know that we have the opportunity to turn this around. And so I'll pass along, if I could, to my colleague, Dr. Jim Souza, to reflect the experience of St. Luke's and some further information.
Thanks very much, Steve. And I want to thank everyone for the opportunity to speak with you today. If we could just create a little bit of context with the slides, Anita, and then I'll quickly pivot to other comments. I wanted to first show our testing outputs, and you can, the bar graphs speak for themselves here. We've had a huge surge in the number of positive tests, and by the way, the drop off you see at the end there is largely due to lag time in reporting. You go to the next slide. This is what hospitalizations look like for us in the first part of our experience with this pandemic, and you can see it sort of looks like potential victory. Next slide. Until this happened, and this is what's happening now. And for information, our short-term forecasting model would predict that, as has already been mentioned, we will double these numbers within 2 weeks at current rate. So we'd be estimating roughly 150 admissions. That's all on the slides, Anita. You know, I think what I'd like to use the remainder of my time to do is to give a message to the community about how we'd like your help in engaging with us to solve this problem. I want to create a bit of a what's in it for you. Beginning with the fact that our healthcare facilities are critical resources for every citizen in Idaho, man, woman, and child. I don't know if you're going to need one of our amazing facilities tomorrow or next week or next month or next year or in 10 years. But I'm highly confident that someone you know or love is probably going to need one of our facilities in the next few weeks to months while we're managing through a pandemic. And the bigger your social circle, the more likely that is. The second point I'd like to make is that our amazing healthcare facilities here in Idaho are already busy taking care of sick people and saving lives. We provide care for all kinds of acute disorders like heart attacks and strokes and trauma and acute infections. We manage flare-ups of chronic disease. We manage new diagnoses of cancer, and we provide any number of life-saving, urgent and emergent surgeries. The third point I want to make is that this pandemic can turn on a dime. And to be clear, any added COVID activity is added to all of that work that we're already doing. That obligation won't go anywhere. It's still there. And I want to share our experience from Blaine County, where around the end of March and the first week in April, we experienced a surge. We were fortunate in that it was contained to a very small population, about 25,000 people in Blaine County. But when COVID ran through that county like a wildfire, you know, our capacity for care got burned. We had to close a facility because we had so many of our coworkers infected, having acquired it in the community. Moreover, we have a facility in Twin Falls, Idaho, which was the recipient of the fallout from that outbreak. And, you know, I'm a critical care doctor, still practice part-time. And I can tell you that what we saw play out there in Twin Falls was a once-in-a-lifetime experience for me. I've never seen anything move this quickly. We saw a standard intensive care unit, general medical surgical ICU in a community hospital transformed over a period of 5 days. When I say transformed, I mean it went from a, you know, average census general med surg ICU to an ICU that was completely filled with respiratory patients, all of them with COVID, most of them intubated, an intermediate care unit that was surging full, an anesthesia team that was, you know, because we'd shut our surgeries, moving up to the ICU to create an intubation team to intubate patients. And then we started airlifting people to the west, here to Boise and to Meridian to offload that surge. It was a white knuckle 5 days, the first 5 days of April. We did not know if there was even going to be an end in sight. We didn't know if the governor's shelter-in-place order was going to work, and then it did. And key to this disease is this lag time. The governor, 1 week before we had started seeing the surge, had put the shelter-in-place order in place, and so we were the benefactors of that 2 weeks later. So when you start seeing infections, it'll be a couple weeks till you see hospitalizations, and a couple more weeks until you start seeing ICU hospitalizations and deaths. The fourth point I'd like to make is that we can create increased bed capacity, but as you've already heard from our colleagues at St. Alphonsus, we need people to provide that care. And just like St. Alphonsus, our people are now acquiring this infection in the community. They live in the community too. And so our capacity to provide that care will be constrained. I want to ask folks to go through just a brief mental exercise here for just a second. You know, you all have jobs, and I want you to think about your jobs. And I want you to pretend that your boss, he or she, asks you to increase whatever you do by 10% in about 2 weeks. So if you make things, you got to make 10% more. If you write things, write 10% more. If you sell things, sell 10% more. If you buy things, buy 10% more. If you mow lawns, mow 10% more lawns. You could probably pull that off. What if he or she asked you to do 20% in 2 weeks? You might start saying, can I get some more resources? And he or she would say, no, in fact, we're going to constrain your resources. You actually get fewer people to do the work you need to do. You might ask, can I take some things off my plate? And he or she would say, no, I expect you to continue to do all of the things that you need to do. Now imagine that it's 50% and it happens in 1 week. And remember that your job is actually not making things or buying things or selling things. It's actually saving lives and taking care of sick people. And you can start to see the problem we're facing and how we need our communities to engage. So in order to protect this resource for all of us, we actually need that engagement. In our health system, you know, unfortunately, we do have the experience of seeing one of these explosions of COVID in a contained population in Wood River play out. Fortunately, that was in a contained population of about 25,000 people. Play that forward to our population here in the Treasure Valley, in Ada and Canyon counties and beyond, of 800,000 plus people, and just do the math. And it's a pretty quick exercise. So finally, I'm going to pivot briefly to what works. We know what works. And I'm going to throw out the 3 W's that somebody shared with me recently. Wearing masks, watching your distance, and washing your hands and surfaces. And I just want to talk briefly about the mask topic because it's very important. And there's mounting evidence that it actually works. And this is an issue of science in managing a pandemic. The lines of evidence are multiple. There's definitely basic science evidence that shows just speaking a phrase creates hundreds of respiratory droplets that vary in size between 20 and 500 micrometers. There's evidence that wearing a mask radically reduces the number of those droplets that we share with other people. Probably more important, though, is the real life experience that we're starting to gain in this pandemic. Some of those lines of evidence come from case series. I'll share for the folks the Missouri hairdressers that made a lot of press in mid-May. 2 hairdressers at a Supercuts in Missouri who, in an incredibly not very wise act, were symptomatic with COVID, tested positive, and went to work anyway. That's what made the news in May. What made the news in June, after they were outed and removed from the workplace, is that they had exposed 150 people in close proximity, but they wore masks all of the time and there were no conversions. That's an important fact. There's similar case series with international airplane travelers. There's mounting now experience, epidemiologic data that those counties, states, municipalities in the United States that have required face coverings actually see a decrease in the rate of rise of COVID cases. So we know what works. I won't dwell on the other 2. I want to use the phrase that it's about the air we share. And if we all take these simple actions, we can change this rate of rise and protect our capacity for care. I'm going to turn it now to my colleague, Dr. David Peterman. He's the CEO of Primary Health Medical Group.
Thank you, Jim. I want to make sure everyone can hear me. I'm speaking from the perspective of a primary care physician, and I'm following my notes very carefully because I want to make sure I get the numbers correct. So since the beginning of March, we have seen over 130,000 patients in our 19 primary care clinics. We've seen over 20,000 patients in our respiratory clinics, which we test for coronavirus. Now, as a pediatrician, I spend a great deal of my time reassuring patients that their children are growing and developing normally. Today, I'm not here to reassure you. I'm here to tell you, as the adults and as the parents, we need to take action now to protect the children, our friends, our families, our neighbors, and grandparents. So, Anita, if I could have the first slide. So this slide shows you the number of cases per day of coronavirus in our clinics. And if you go way to the left, where there's sort of a peak, that's end of March, beginning of April, when there was the highest peak, and when Jim and Steve were referencing when there were increased admissions for coronavirus. If you go all the way to the right and you see the enormity of those bars, that's where we are today. So back in end of March, early April, we were seeing 10 to 15 positive cases a day in our clinics. Today, it's at 40 to 55 positive cases a day. Now, the obvious is you might ask, well, you're just testing more, and you'd be right. But there's something else here I want to show you, which is very worrisome. Again, can I have the next slide, Anita? Okay, so what this slide shows you, which is the one I'm so worried about, these are graphs that show per week the positivity rate of testing. So that's the percentage of positive tests based on what we have done weekly. So again, if you move towards the left and you look under the end of March, beginning of April, the positivity rate was 5.7, 4.4, in that range, which was the height of where we were with coronavirus. Then you see, following sheltering, as we get into May, it drops down to 1.5, 1.2, and then look at this enormous spike in June and where we are today, where it is averaging at 15%. That is 3 times the worst we were at, the highest, in April, and it's 7 times where we were at in May. So the World Health Organization and frankly, the majority of infectious diseases experts around the world or in the United States look at the figure of a 5% positivity rate or less as demonstrating you have control of an infectious disease. In our case here in the Treasure Valley, we are 3 times that amount, and it tells you how worrisome this is. So what does this mean? So in the case of primary care and primary health, we're seeing over 400 patients a day in our respiratory clinics. During April, we had 3 respiratory clinics. We have to open up 2 more. We now have 5. There is such a demand for testing that we're scheduled out 2 days in advance. So if you want to if you come and call and say you want to test today, let's see, today's Tuesday, Wednesday, Thursday, we'll hopefully schedule you for Thursday. And even with this kind of scheduling, we're having to turn patients away for testing. And these aren't just people who are saying, I want to be tested. These are patients that either have a close contact with a positive or they have symptoms. With this high positivity rate, we are having hundreds of patients who want test results, who want to know, well, if I'm negative, what do I do? And if I'm positive and I'm not better, what do I do? What about my family members? What about my neighbors? What about work? Now, Jim and Steve have described that obviously there are some of these patients who end up in the hospital, but the vast majority do not. However, there are many of them that have symptoms and they have to be managed, and they're managed by primary care physicians and nurse practitioners here in the Valley. These patients may have chronic cough, may have fatigue, shortness of breath, headaches, and other symptoms. These patients over a week, and again, remember, we're testing 400 daily, and that's just us. That quadruple that for the rest of the community, or 5 times that. Patients over a week generate hundreds of calls daily. Now, our average call in to our clinics of primary health is somewhere around 1,000 a day. Currently, it's over 2,200 phone calls. If you think in terms of what Jim described to us about the capacity to handle patient care and limited resources, the primary care providers become overwhelmed. It makes it very challenging for us to take care of the patients who have diabetes, who have hypertension, or follow up for their thyroid problems. We only have so many resources. It's very, very worrisome. The community spread has, like Jim and Steve have described, has affected our staff also. We currently have over 20 of our staff members out. They either have a positive, had a contact, or they're waiting for results. We actually had to close a clinic this weekend because we didn't have enough staff. Now, there's 2 other things I would just want to add. Despite what you hear on TV about this, with this high rate of positivity, as a pediatrician, I have great concerns about opening schools. And frankly, I'm worried. When you have this high a prevalence in the community, it's close to impossible for there not to be spread, no matter what you do in the schools. And I might also add, and quite a few of the parents of my patients are teachers. I'm not sure that there'll be enough teachers willing to come back to school when we have this high of a positivity rate. Now, I wanted to show you one more slide. If we could bring that up, Anita, that was the colorful slide that we showed. There it is, perfect. Okay, thank you. So this slide is very scary to me. It's not as complicated as it looks. And again, the dates are similar to what you've seen. Over the left is March and April, and over to the right is where we are now. So the colors represent age groups of patients that are positive per week. And what I want you to focus on is so the orange is the 18 to 39-year-olds. This was the group that in June was frequenting the bars. The gray is 40 to 59. Again, we're heading closer to that age of, which is the yellow, of 60 and above, which we know are high risk. So looking back at March, you can see all the colors are way lower. But I particularly draw your attention to the yellow, which is the over 60. And if you look at those over to the left, there's 1 patient or 0 patients. But now if you go all the way over to the right, look at that progression. It starts at 2, it goes to 8, it goes to 19, it goes to 24. And I might add, for that last grouping, I don't have all the results back that will go into that. If you're Steve and Jim, you're very worried about that, because as that proportion gets higher, the yellow and the gray and the orange begins to drop some, Now we're beginning to get the patients that are high risk. So what can we do? I'm going to say the same thing everyone else has said. First of all, absolutely, we have to wear masks. It's not just me, it's everyone else has to wear their masks. We have to distance and we have to wash our hands. And I might also just add one other item, which is we have to be very careful about congregating inside, because we know that leads to more spread. Again, I'll mimic what's already said. Our mayors, our county commissioners, health departments, they do need to take action to slow the spread. There needs to be mandates for masking and distancing. So again, I'm a pediatrician, and not surprisingly, one of my heroes is Mr. Rogers. And so I want to end with a quote from Mr. Rogers, which is, quote, "Real strength comes from helping others," unquote. We need all of us to help solve this virus. Now I think I'm introducing Betsy.
I think so. Thank you, Dr. Peterman.
Yeah, thank you.
And thank you for allowing me to be a part of this and having the opportunity to speak to all of you today. You know, our perspective here at West Valley is focused really on a single community hospital in Canyon County. And certainly we're seeing the same trends out here in Canyon County that we're seeing in other parts of the valley. We are seeing a rapid increase in our COVID case volume. And although at this time, like the others, we have the PPE, the staff and the testing supplies to manage our current operations, the trajectory is very concerning. And I think I just echo what everybody else has said. But to put it in perspective for us, in March and April, we averaged about 1 COVID admission a week. And since June 19th, we've averaged 9 COVID admissions a week. Also, like the others, what is equally concerning is really our staff have been affected by COVID-19 through different activities in the community, as well as, you know, just in their family and their homes. We've had as many as 30 people out. The number is starting to trend back down, fortunately, but over the last couple of weeks, we've even had to divert patients due to staffing. So it has been a significant issue for us, and probably our biggest concern from a resource constraint standpoint. West Valley is part of HCA Healthcare, and so HCA has hospitals throughout the country, particularly in Florida and Texas. So we're seeing firsthand what's happening in those states. Hospitals there are at full capacity with a lot of staff sick calls. Again, that's been the major constraint. I think in those areas, they're asking for help for staff from throughout the country, asking us to send staff there to help, which frankly, we don't have the capacity to be able to help at this point. Canceling procedures and running out of testing supplies. A particular concern is their ICU capacity, just because those patients stay longer. Patients on the vent are on vents longer, which uses more vents because people aren't, coming off to be able to put another patient on. And again, that makes it difficult for other critical patients to be able to get the care they need. So I'll just echo what's been said. Now is the time for us to make a difference, and hopefully before we reach a crisis like what they're seeing in some of the other states, in addition to hand washing, social distancing, a culture of masking will allow us to keep our economy going while minimizing the spread of infection. I think that's a really important point. This is how we can continue to keep our economy up and businesses open, is with a culture of masking. And our healthcare workers need your help. We need our communities to take this seriously, to practice good social and physical distancing, and we're fully on board with the Mask Up Idaho initiative. So that's all from me, and thank you. And I think I'm going to turn it back to Chris or Anita.
Thank you. So, Anita, I just have 2 slides that I think will echo everything that we've been saying. So if you could bring the first one that says safety tips. We're coming to you as your healthcare providers. We are here for you. We are asking for your help. I think that our colleagues, I got to tell you, are scared about what's happening. They want to be here to service this community, not just focus on one item, which is the pandemic. So avoiding large groups, 6 feet away, wearing a mask, good hand hygiene is critical. And we have to act now. We cannot wait until August. I got to tell you, if I was a parent of a young child the dilemma that I would find myself, the emotional and mental stress of whether or not they should go back to school, is something that we could prevent for many parents if we just follow these 4 practices. The next slide just gives you an idea of, how much risk are you willing to take, in activities, and we can share this with you. But for example, if I decide to go, to a pool party where I don't know half the people and there's 50 people there, and I go to a buffet, that's high risk versus, ordering out and going camping in this beautiful state of ours. We've always united together to solve problems, and we're urging you as your healthcare providers to join us on this quest of mandating masking, social distancing, and like Betsy said, we can open our economy with this. And with that, I'll turn it to Anita so we can make sure we have time to answer questions.
And I want to thank everybody for participation again. And just one final point. This is a serious conversation and sobering statistics and facts for sure. But I want you to know that as a healthcare system, a collective system, we are not panicking. We are not in crisis. I hear often that, well, the hospitals have enough beds, so we must be okay. We are taking care of everybody who needs care today, and we will continue to do that. But August will be too late, and we will find ourselves in a situation where that could very well change. Hospitals and clinics are safe places to be. Our healthcare workers are being exposed to coronavirus in the community. And as you've heard over and over again, they are our most critical resource going forward. So again, wear a mask, watch your distancing, wash your hands in clean surfaces, and call on your local officials to do their part. Thank you.
Thank you, Chris. Again, if you have a question, please raise your hand. We'll try to call on you in the order that we see those. State your name, your organization that you're with, and who your question is directed to. And I just want to remind you that we also have Dr. John Kaiser on the line and Dr. Sky Blue, and both can share their perspective. Dr. Kaiser is an OBGYN working directly with patients, and Dr. Blue is an epidemiologist for your questions related to that. We'll start with Audrey Dutton from the Idaho State. Go ahead, Audrey, unmute yourself.
Hi, this question is for Chris Roth. Actually, 2 questions. One is more of a clarification. Are you calling on people to ask for a mask mandate or a mask expectation? Because you mentioned requirement and then expectation. And so if you could clarify that. And then my other question is, if the shelter-in-place order was necessary to stop a wave like this in April in a place that's 1/30th the population of the Treasure Valley, what in the projections says that anything short of that will be effective now?
Yeah, thanks, Audrey. First of all, just to be clear on your first question, we collectively would like to see a mandate relative to masking. So just to be crystal clear, and you've heard some of my colleagues speak to that. And I may call on some of my physician colleagues as well to answer the next question. But, if we think about, we know a lot more now than we did back in March and April. And unfortunately, there were incredibly mixed messages relative to masking. Do we wear them? Do we not? Do healthcare workers wear them? Yes, but the public, no. And science has advanced. We've learned more. And we do have the evidence that shows that the trend can actually be reversed by following the 3 W's, if you will. And we've got people on the line much more qualified to speak to the science behind that. But that's really the difference, Audrey, between what we saw then and what we see today. And, this has been certainly a pretty stark layout of the data and the information, but we are optimistic that we can turn this again without shutting things down. There are too many bad things that can happen when we go back to the stay-at-home order, including the impact on public health that I spoke about earlier. So I'd kind of leave it there and see if anybody else has anything to add.
Audrey, this is Jim Souza. I'd just say that the shelter-in-place order, while effective, was a blunt force instrument. We don't want to see that used again because of the other negative effects that it creates. Unfortunately, the science has been catching up here, and we know that these more precise interventions around masking and distancing and avoiding congregating indoors, they'll work.
Audrey, Stephen Emerson, I think you're also asking about the situation where in a rural community, the incidence of COVID may be significantly lower. And the fact is, it has to do with one-to-one transmission, human being to human being. And the risk of transmission is dropped dramatically by simply both parties wearing a mask. It's scientific evidence most recently suggests with source containment, that infected individual likelihood of transmitting the virus to somebody else can be reduced by 85% or greater. And so even in the community where you're unlikely to come into contact with somebody who has COVID, you don't know who's driving in, who's going to be crossing your path, and you should protect yourself and they should protect you.
Our next question is from Colin. If you can also mute yourselves if you're not speaking. Colin, go ahead and ask your question and state your organization.
Sure. Hello. I'm Colin Tiernan, and I'm a reporter with the Times News in Twin Falls. This question is kind of really for anyone from St. Luke's. I know that you guys here are working on getting nurses trained as you're preparing for more and more cases like you're talking about. And I know those trainings are mandatory. And I've heard that nurses are being asked to provide their own masks. And I was just wondering why that might be the case. Do we just not have enough masks for our nurses?
Yeah, this is Chris, and Jim certainly add on. We have plenty of masks for our healthcare workers. We have adequate PPE supplies. So I don't know specifically what you're speaking about relative to training and mask provision. We do ask all of our healthcare workers and our team members to utilize their own mask when they're out in public.
Agree with
Next
Chris.
question. Let's take the next question from Mike Baker from the New York Times. Mike, go ahead and ask your question.
Yeah, thanks for organizing this really helpful conversation and presentation. I'm hearing a lot of focus here in the discussion on trying to get various local agencies to embrace masks. Would you all like to see any sort of statewide mandate? Have you had any conversations with the governor's office, and what kind of response have you heard if you have?
This is Chris. I can take this initially. I think, in Idaho, we have 7 public health districts. They're all doing different things. They're not coordinated, they're not consistent, and we have a patchwork quilt of solutions as a result. The governor, to his credit, is wearing a mask. He's encouraging people to wear a mask. He's leading by example, as are his colleagues. However, we would like to see more state action as it relates to mandates that leads to a coordinated response with all 7 public health districts and then related communities.
Chris, this is David Peterman. Let me just say, we have a rich source of data based on some of what you saw. A map that I have shared with Dr. Souza shows where the residents of the cases we've tested at primary health. In a sense, they are everywhere, all over Idaho. And so any notion that mandating masking just for Boise or mandating just for Canyon County, I couldn't agree with Chris more. That's not going to work. Again, the governor has been very strong and the governor has been emphatic. And I don't claim to be a politician, but as a physician and based on the data I'm seeing, which is people are coming from all over Idaho to be tested and therefore moving all around, I strongly would recommend a masking mandate for the entire state.
Yeah, and this is Odette with St. Al's. I would just share something that came out actually of the Wall Street Journal on May 5th of this year. that showed that 64% of the cases across the country originated from New York City. So, that's people getting on a plane and traveling. We're traveling, our boundaries are very blurred, and we're traveling from one community to the next. So I think we are very much urging every single area in Idaho, every public district, to mandate masking.
I'm sorry, one other thing, and I would share our maps with the media to show. It's very dramatic. If that's something you would need, Anita can coordinate that or somehow email me, and I certainly can send those maps through our director of marketing to any news media that would want it.
We'll be happy to get those to you. Our next question is coming from Nicole.
Hi, this is Nicole Camardo with Idaho News 6. My questions are for anyone from St. Luke's or St. Al's who can speak on this. Number one is, how close are we to the capacity of hospitals being filled? And what are the availabilities, like where are we with tests and turnaround time?
I could.
So I can.
Sorry. Go.
So for St. Al's, if I can just talk for St. Al's, Dr. Peterman did a great job in talking about testing, and we've read all the articles that, basically over the last 4 weeks really crippled the testing capacity, and we're starting to see fragility in that. Dr. Nemerson also talked about, we were very focused on testing asymptomatic people. We've had to pull back. Now, some of the labs, the retail labs, are getting back up into being able to do more, but there are still significant issues. We do, like St. Luke's, have in-house testing, but we are trying to manage that for the most critical patients and to keep our colleagues safe. So we continue to urge, the need to really deal with this on prevention and mitigation versus mass testing. I'll defer to Jim or Steve on any other comments on that.
I just want to make a comment about the capacity for care that the questioner asked, how close are we to our capacity? I think perhaps a more important question to answer is, how are you doing compared to your usual capacity? Because that's what you're actually designed to deliver. Here at St. Luke's, our intensive care unit is consistently operating at 130% now of what is normal operating volume for us. We're managing that. We're managing it well. As we continue to see increases, though, and then push toward capacity and have to consider expanding capacity and even closing other units, other things will have to give. First and foremost would be elective surgeries.
And Steve Nemerson from St. Alphonsus, I'll tag along to that to say we've already made the decision in order to preserve normal operations to discontinue some of our less urgent procedures or postpone them further. So without giving an exact percentage, we've been doing that for approximately a week now. And as the numbers continue to climb, we're going to have to balance increasing the volume of COVID patients and decreasing the volume of patients that will have to wait to receive the urgent care that they require. The last thing I referenced earlier is, at the current growth rate, we could expect within our 4 acute care hospitals to have up to half of our total patient volume be COVID positive by Labor Day.
At this point, I want to allow Dr. John Kaiser to make a quick statement, but Shira from KTBB will be next after Dr. Kaiser is done.
Yes, I just want to thank you for the opportunity to speak a little. We've experienced at Salter Health the same testing, the same results that has been mentioned. I would like to just make a comment from a personal physician standpoint. I take care of many obstetrics patients, and I cannot tell you how concerned they are for their own health and the health of their children. They ask constantly, what can we do to help prevent us from getting infected and protect my child? And it's the messages that we've just delivered. And I think that is the reason that we are bringing this forward, is it's very important for patients, community, and everyone else to be on the same page and understand the importance and that we can slow this down. So that's my plea to everyone.
Thank you, Dr. Kaiser. Go ahead, Shira.
Thank you, Anita. I think Dr. Nemerson kind of touched upon this earlier, but in terms of these COVID cases, what type of treatments are being used in hospitals, and are they showing any promise? And I guess along those notes, are there any medical trials that are happening here in the hospitals currently as well?
Sure, I can jump in again, Dr. Nemerson. So the trials that we are already participating in are the ones that you've already heard on the national media. We've provided in St. Alphonsus the delivery of remdesivir, which is an antiviral medication, to at least 2 patients in recent months. We have access to convalescent plasma, which is the infusion of coronavirus antibodies from a patient who had previously been infected into a patient who has active coronavirus disease. And then the other therapies that have shown significant promise are the use of steroids and anti-inflammatory drugs. We have access to all of those, as I imagine all of the facilities around the state do. The issue then becomes one of supply and demand, and there's some trickiness, which I think is an important aside for remdesivir specifically, which is that medication at present cannot be transported across state lines. And so the supply that we have in the state of Idaho through the public health department and the individual facilities have is what we are stuck with for the moment. And we are strongly advocating at St. Alphonsus that regulation be changed nationally, because we are a national organization, Trinity Health, and we have supplies throughout all of our ministries, and we want to get the medication to any patient that needs it. Rest assured, though, at current state, we have more than enough therapy to serve. And last thing is I need to remind everyone that we have no cure. There are some therapies that show promise for improving outcome, but not stopping death. And this is about taking care of the community, keeping people well, keeping people who get sick from getting more sick, and keeping those who get really sick from dying.
I'd only add to Steve's comment. We do have a clinical trial happening at St. Luke's with one of the anti-inflammatory drugs, tocilizumab, it's called. Echoing what Steve just said, these improvements clinically, they're important. They really can make a difference, but they should be seen as incremental improvements in care. We don't have a silver bullet yet, and the end of this and getting out of this either looks like herd immunity that we can create with a vaccine, or really effective treatment, like Steve just suggested, that renders this a harmless and manageable condition. We don't have that yet.
I will remind you all, if you're not part of the presentation, to please turn your cameras off. We appreciate cats and other things in the background, but it's a bit distracting. So I'll open the next question up to Benito.
Thank you. I'm with News Radio 1310 in Twin Falls. I just a question regarding the healthcare workers that have either had to be quarantined or came down with COVID-19 and they're catching it within the community. Is there a concern that maybe they're mingling, interacting in groups, or not wearing their masks, or is it contact with members of their family that caught the virus through another social setting?
Can I answer that one? This is David Peterman. So we contact every positive case that we have, and that of course includes employees. And with the employees, we actually have what we call our COVID response team, which follows up with the employees, and we do our own internal tracing. I can tell you that we've had, if we look at all the positive, which is less than 11 with 600 employees, with the exception of early on when we didn't early in March, when we didn't totally understand about masking and we didn't totally understand about distancing, we had 4 cases positive in one clinic where an individual seemed to have got it from someone at home. Every one of the other cases are all from community spread. And in some cases, our employees, as not surprisingly, went to bars early in June. So I want to make it very clear. I know I'm speaking for all the healthcare providers on the phone. The healthcare providers, of course, were not perfect, but they understand about masking and distancing and washing their hands. This spread is from community spread, and I'm just emphatic on that. This is not coming from the healthcare workers giving it to others. I mean, is that possible? Yes, but this is community spread, and frankly, we have the data to prove it. The fact that we have had 130,000 patient encounters, but so few positives of our organization, and again, same with the others, it's not internal, it's community spread.
Next question is from Rachel Cohen.
Hello, this is Rachel from Boise State Public Radio, and this question is for Dr. Souza. So when the Wood River Hospital was overwhelmed, patients were moved to Twin Falls and then Boise. What would it look like for the Treasure Valley hospitals to be overwhelmed? And how would you know when you've hit that point?
Yeah, a point of clarification, the Wood River facility wasn't overwhelmed. It was shut because we didn't have enough healthy hands to take care of people being admitted there. Moreover, the Wood River facility does have 2 beds that are technically critical care beds, but truly are more like step-down beds. So those acutely ill patients needed a higher level of care anyway and would have moved. But Rachel, I think your question was, what would overwhelmed look like? We don't have to be very imaginative to visualize that in our hospitals. We actually just we can look at what's come out of, the Texas Medical Center and, hospitals in Arizona and hospitals in Florida, and early on in the pandemic, hospitals in New York. What it looks like is day by day, healthcare systems making the decision to shutter a telemetry unit, to shutter a med-surg unit. What it looks like is day by day, pulling in staff that don't usually work as critical care nurses or don't usually work on a med-surg floor to be the healthy hands to provide that care. It means healthcare systems deploying new provider, physician and advanced practice provider, NPPA models to round on a surging number of patients. It potentially means deploying people who aren't critical care doctors in creative ways. And we've been, I think we've all been practicing and drilling how we would do this to support delivering care in a different way. It looks bad.
We're nearing the end of our time here. Paula has a question. We'll go ahead and allow you to ask your question as we get ready to close this news conference. If anyone else has a question, please let us know.
Thank you for the opportunity, and thank you for the time that you've taken to unite and share your message with our community. My name is Paula Keller. I'm superintendent of Nampa Schools. My question is, really good information. Would the folks on this call would you consider helping our schools in these decisions through a joint written statement? We have the opportunity, much like you do, to work with several patrons and stakeholders with various views. As you might imagine, it runs the gamut from those who would completely support face coverings to those who absolutely are adamant against it. I do believe a written statement would help us as we share and try to educate our community and our stakeholders. So in essence, written joint statement with some of the information that you've shared today.
That is something that this group can discuss. Paul, I appreciate your question. It's a good question, and this is something that this group can discuss. They meet weekly to talk about these kinds of issues, and it's one of the things that they can discuss at that time. I want to open it up to Dr. Blue, who's joined us the whole time. Does anyone have questions specific to the epidemiology of what we're seeing, whether it be spread rates or anything like that, that you would like to ask a question of Dr. Blue about? Go ahead and unmute yourself and ask your question if you have a question for Dr. Blue.
I can just go ahead and, sorry, I'm on feedback there. I can just go ahead and highlight a couple points that the physicians and administrators have been doing, and been truly amazed on how they've stepped up to understand this new disease. And it's humbling for clinicians, because we've always known that viral illnesses really do not respond to a lot that we do, and we have to fall back to supporting the patient during that time frame. You talked about a lot of different therapies that are coming to the forefront, and we really stand on the shoulders of our colleagues who've been, treating this in China, Italy, Seattle, and New York. And so at this stage, we do recognize this disease process so much better than we used to. We realize the disease patterns that we're seeing, and we're trying to come around with a systematic way to study these conditions so we know how we can best take care of the patients. And even from March to today, I think we understand this disease better, but again, it just continues to humble us as this viral illness takes shape. A couple points on the masking, and we say, well, why didn't we start this earlier? We are in a vastly different stage of this illness than we were early on. When we had, less than 100 cases, our contact tracing, our quarantine, our ability to isolate this and restrict transmission was so much better than it is when we have 500 cases a day. You talked about the turnaround time between testing and results, the turnaround time between appointments and visits. During that time, there is potential spread. And when you have the percentage of positive rates that Dr. Peterman pointed out, there's so many more people out there that are either asymptomatic, pre-symptomatic, that don't know that they have the disease. And that's why we're just going to everybody who is in a physical closeness to others to protect our air. Use that mask, reduce those transmissions even before you become symptomatic. That's the stage we're in right now. If we get back down to a handful of cases each day, then our contact tracing works. Then our quarantine of individuals who have had contacts with those individuals will work. But we're beyond that right now. We need to take it to each and every individual who is a member of our society to really help us decrease this inflammatory disease and this transmission. And that's why I think we're all coming to you now.
Thank you, Dr. Blue. And I want to thank everyone for their time. I also want to be respectful of time. It's 11:20. So we appreciate your questions and your engagement. This recording will be posted online later on today so people can go back and watch it. And if you have any further follow-up questions, feel free to reach out directly to me and we'll work to get you those slides as well. So thank you so much for everyone's involvement and thanks for your time. Be well.